Hey everybody, welcome back to the Daily ECG here. My name is Reid. Don't forget to download the PDF in the description so you can follow along and like and subscribe so that you can support the channel and get notifications for the next day's ECG. So let's jump into this one. This is a fun one. This is a tricky one. There's a lot going on. So first thing we're going to do is look at the forest, and the trees of our forest are our QRS complexes. So I like to just get an idea of what's going on. I might maybe use V5 here. It seems like we've got this narrow complex QRS that is occurring, seems to be slow, and then a little faster. And then we've got this funky beat here. And then it seems to get a little faster and then slower again. So it seems like maybe there's some intermittent periods of slowing of the conduction here. Slow. And then we've got these more faster, rapid conduction here that I'm having red. So that could be caused by various things, and because it's a narrow complex QRS, I have a high index of suspicion that conduction is occurring through the AV node and through the His-Purkinje fibers, because we know that that is how a narrow complex QRS is formed, is because if you look at our diagram of the heart, when signals get passed from the atria down the AV node through that bundle branch, right, left bundle branches into the ventricles, that causes a narrow QRS. So probably got a rhythm that's coming from the atria of some sort, but it's obviously not incredibly regular, and so let's kind of suss this out a little bit. So what is the atria doing? Step 2. And do I see P waves in front of my QRSs? If I look here in V1, what you'll notice is we do have a P wave right here. That's a nice looking P, and that P wave does conduct to this QRS, and we can see that here again in lead 1. Those P waves that are that we see here, that was lead 2. But if we look up here in lead 1, that P wave is upright in lead 1. And if we look down here in AVF, we can see in front of this QRS, we see a little deflection positively here. That's another P wave. You can see it again right here at the P wave. So the P waves are upright in 1, upright in AVF. So that is a sinus P wave. It's important to figure that out. And what we'll notice, we'll kind of blend steps 2 and 3 in together. Let's take a look at our PR interval. Our PR interval is indicative of our AV nodes function. And so initially, we see that we've got the P wave, we'll go right here to lead 2. The P wave starts there, and the QRS starts there. And I would say that that PR interval is greater than 200 milliseconds. So we know that there is some type of AV block because it is taking too long, but we need to figure out what kind of AV block it is. And so what I'm going to do is, my thought process is this. I've got a nice couple of beats in a row here. The rate in between these beats seems to be, if I start there, 300, 150, 100, 75, maybe 70 beats per minute on those beats. And then here, if I time this out between these two beats, it's roughly half of that. So we see here that it's maybe 35 beats per minute or so. So maybe there's some dropped beats. And so let's just march through and just figure out what we see. I'll start here with this beat here. So I've got this P, and that P conducts to our QRS here with a prolonged PR interval. Then we have another P that gets blocked. Okay, so that P doesn't conduct. And then we kind of start the cycle over. P that conducts to the QRS. And then if you look here, there's another atrial activity right at the end of that T wave. Right at the end of that T wave, you can see there's this little hump that's a P wave. I know that that's a P because I compare to the previous T wave, and I can see that it's different. And so that's a non-conducting P wave as well, maybe even a non-conducting premature atrial contraction, I would say, because the P wave morphology is different. So that's actually a non-conducted, a blocked PAC. But what you'll notice here, when we move to this run of beats, that we've got P that conducts to our QRS, we've got a P that conducts to our QRS, but notice the PR interval is getting a little longer. And then we've got another P here that conducts to the QRS with an even longer PR interval. So the PR intervals are getting longer and longer and longer until they drop. And if we look over here and continue, we've got P, QRS, P, QRS, and then we've got this last P here that is blocked. And those P's are getting, the PR interval is getting longer and longer until it drops. And so that is a second degree type 2 AV block because the PR interval is getting longer and longer and longer. So we've got a second degree type 2 block. It's kind of hard to suss that one out a little bit. Our QRS duration we said was narrow. If we look and measure it, we see our QRS duration, if we look here in V1, is QRS is less than 120 milliseconds. My QRS axis is upright in lead 1. It appears to be isoelectric in AVF. So the QRS axis, if you look down at our heart, is probably going straight towards lead 1, perpendicular to AVF. So that's a normal axis. And now we're going to look for pathological Q waves or ST or T wave changes. And I see, when I look for pathological Q waves, I'll do this in green. Look at my inferior leads, lead 2, lead 3, and lead AVF. Look at these deep Q waves. That's a Q. There's another Q. And there's another Q. And that's a pathological Q wave. Pathological Q. That's important because what that means is that the Q wave amplitude is large enough to indicate that signal is not traveling in that direction well, because if it's negative, that means it's going away. And so that tells me that there is some type of myocardial infarction that has occurred, in this case in the inferior leads. We have inferior pathological Q waves. And that tells me, pathological Q tells me it is an old MI in that region. The thing is we don't know how long ago that was, right? The time, it could have been yesterday, it could have been 10 years ago, 20 years ago. But if you compare this also to our ST and T waves, what you'll notice here is in those inferior leads, we do have a little bit of ST elevation. We do have ST elevation there. If you look in AVF, and even just a slight amount there, not too much. We also, in the lateral leads, that is lead V5, V6, we see we've got ST depression here in our lateral leads, V5, V6, even so in lead 1 and AVL. So if you put that all together, where you've got ST elevation in the inferior leads, so let's write this down. We've got inferior, so we've got inferior pathological Qs, we've got inferior ST elevation, and we have lateral ST depression. So that tells me that this elevation is really caused by ischemia because we've got reciprocal depression. In the inferior pathological Q waves, there's a good chance that this is developed because of an evolving myocardial infarction. So my guess with this ECG is that this person is having an inferior STEMI. And the problem is with this inferior STEMI is that we're catching it a little bit late because Q waves don't develop until that myocardium dies. So we've already seen a little bit of death of the myocardium, which is represented by these Q waves. And there's still a little bit of remaining ST elevation, indicating that there is some still ongoing ischemia. Something we also noted is that we've got this second degree type 2 AV block. And why does that tie in really nicely with this ST elevation changes that we notice is that oftentimes the inferior leads, which can represent some of the right ventricle as well as our AV and SA nodes, can be supplied by the right coronary artery. So this person is likely having involvement of the right coronary because the right coronary branches off into our SA and AV nodes. So if our right coronary is blocked, our AV node is not going to work so well, which is what we see, as well as some of the inferior and right ventricular involvement in this MI. Last thing we need to do is we need to readdress this funky beat that we said right here. This funky beat, it's a wide complex beat, so it's premature, right? If we measure out the intervals between these two, it's definitely early. And if you look in front of it, I don't see any atrial activity. So this is a premature ventricular contraction. All right, so let's put this all together. What do we got? We've got a sinus rhythm, potentially with a PAC down here. We've got a second degree type 2 AV block. This person's in big trouble. We've got pathological Q waves in the inferior leads, as well as ST elevation in those leads, with reciprocal depression in the lateral leads. This tells me that there is an evolving myocardial infarction, potentially involving the right coronary artery. So I hope this helps. This was a really tricky ECG, a lot going on, but if you put it all together, it'll make sense, and the anatomy makes sense. So if you don't understand the anatomy of the coronary arteries, go back and study those. That really helps you, when you see this AV block, well, what supplies the AV node? So have a great day. Tune back in for tomorrow's ECG of the day. Subscribe to the channel if you enjoy this stuff. And yeah, see you then.